Today, the topic is related to hemodialysis prescription. What are all the information a doctor, treating doctor, a nephrologist, or a physician, the information you have to pass on to the dialysis technologist so that the treatment can be started. Why this is required? Because we have to inform the patient details so that the dose or whatever the parameters in the machine can be set accordingly. Out of which the major information we have to tell is, first one is the duration of dialysis. Not all dialysis is for 4 hours. The first dialysis, if we are initiating, or if we doesn't want to give much clearance. What is clearance? Urea, creatinine and other waste products get accumulated in the body that we call as uremia or azotemia in the lab report wise. That have to be cleared out. Cleared out, in simple terms I have to tell, it have to be washed out of the body. That washing clearance, how much we want, that we have to decide based on which duration. How much duration we want to give the dialysis. On an average it is 4 hours for a maintenance hemodialysis patient. For admitted patient, the duration might vary. Sometimes 1.5 hours, sometimes 2 hours, sometimes 3 hours. So we have to tell what is the duration that we want to give the dialysis for. That is the first one. Second important parameter, vascular access. What is vascular access? From the patient, how we are going to take the blood to the dialyzer. From which route? Whether we are going to put the catheter in the jugular vein or femoral vein or subclavian vein, or we are going to use the AV fistula. That have to be informed so that the dialysis technologist will be aware that is the route that we are going to use. The vascular access, femoral vein route or internal jugular route. We have to decide based on the patient risk and other parameters which one he can tolerate, where we can insert the catheter. With respect to this one, this prescription will be very easy. Why? Because the nephrologist or the treating doctor might have placed the catheter already, or the patient might be having fistula. So the second one route will be somewhat easy, and we have to inform the technologist use this route. Here one point is, sometimes a fistula might be made, but it might not be mature enough. Matured enough for what? Matured enough to start the dialysis through the fistula. So during that time, you can instruct them to put, or you can put the vascular access either in the femoral or jugular vein and ask them to use this rather than the fistula. This is important. Why? If the fistula is not matured, there are chances, if the dialysis technologist is not aware, it is not matured, he might cannulate it. Patient might not be aware that this fistula can be cannulated. So that is why this problem can occur, this can be prevented. Coming to the third one. Third one is related to water removal by the machine. That technically we will call as ultrafiltrate removal. How much water can be removed during the session, during the process. That the treating doctor have to decide. We can't blindly put the ultrafiltrate. Why? If the ultrafiltrate or water removal from the patient is high, what will happen? The urine output will stop or start falling down. That is one. Suppose if the ultrafiltrate that we removed, to be in simple language, amount of water that we are going to remove from the patient is less. For example, the patient is in volume overload because of congestive cardiac failure or CKD or any condition for that matter. We have to remove, for example, approximately 3 liters. That is what we are expecting. If the instruction is not clear, for example, during the session only 500 ml or 0.5 liter is being removed, what will happen? The patient will be in volume overload. The dialysis treatment might not work. The treating physician might be confused why this mismatch is occurring. So that is why ultrafiltrate removal have to be mentioned or clearly given to the dialysis technologist. Here the duration, the initial one and the ultrafiltrate, these both are somewhat interrelated. Suppose if we want to remove ultrafiltrate of, let us take an example of 3 liter. If we want to remove 3 liter and if we duration keep it as 2 hours, you can't remove this much water in 2 hours. the duration have to be extended accordingly because these are interrelated parameters. Hopefully, a nephrologist or a budding nephrologist who is watching, you might be aware these two are related. And the maximum ultrafiltrate that can be removed from this machine to be on the safer side is approximately 500 to 800 ml per hour. To be more specific, it is 13 ml per kg per hour theoretically. On an average, more than 800 ml to 1 liter, if we remove, there is a chance of complication like hypotension. The vascular access can go for clotting. These are all the complication. So, the ultrafiltrate that to be removed from the patient have to be decided prior. The expected rate have to be decided and the duration have to be accordingly adjusted. So what we have seen so far, duration, vascular access, how much water we have to remove from the patient, that have to be very clear. This ultrafiltrate is very important because in AKI patient, if the ultrafiltrate calculation is not clear, the patient might not improve in terms of renal recovery, in terms of clinical recovery, both the patient might not improve. If the ultrafiltrate is not clear in a patient who is on maintenance hemodialysis, his BP might start fluctuating. He might not be feeling clinically safe in the sense the quality of life, he might not be feeling comfortable. Some or other problem will always be there. So that is why the ultrafiltrate is very important. Coming to the fourth one, what we have to tell as a doctor, we have to instruct them regarding the blood flow. Now this machine is not running, so I can't show you the demo, but there are n number of videos in the channel where the running machine we have shown, where here is the blood flow pump. As we adjust this pump, the blood flow will adjust. The blood flow is 300 ml per minute on an average. How much blood flow we want to do the dialysis session, that have to be instructed. Why? 200 ml per minute. Let us take an example. Per hour, the number of liters will be different. 200 ml per minute per hour. We are running the same blood flow for 4 hours. The value will come different. If the same blood flow, if it is 300 ml per minute per hour, this will be different. So it is written as ml per minute. So we might be doing the dialysis for 2 hours, 4 hours. On an average, I am taking it as 4 hours. The blood flow, whatever the blood flow we are going to keep, that will decide the clearance. Higher the flow, higher the clearance. Not only clearance, there are other subtle parameters like vascular access, thrombus. These are related, but to be pertaining to this video, remember blood flow have to be instructed considering the clearance. Higher blood flow, higher clearance. Lower blood flow, lower clearance. A higher blood flow initial time can cause hypotension. So that is why during the dialysis, sometimes we might start with a low blood flow, gradually we will increase it to higher blood flow. This is the fourth important one. Fifth one, as the blood flow is there, similarly, if the dialysis is there, there will be dialysate flow on the opposite side. That have to be decided, how much dialysate flow we want. This is more of nephrologist territory, whereas students might be wanting how much flow to keep. It depends on the blood flow. Approximately double the blood flow we have to keep. Again, this will decide the clearance. The subtle prescription related to this blood flow, dialysate flow is the flow of the blood and dialysate. If both flowing in the same direction, that is called co-current flow. If blood is coming in this direction, if dialysate is going in the opposite direction, that is called countercurrent flow. If you are giving this also as a prescription order, well and good. Suppose if this is not given, most of the unit take it as a countercurrent flow. So that is fine. But we have to give the instruction for blood flow and the dialysate flow. Vascular access we have told, duration, and another one prescription we have to do is related to the clotting. Clotting, as the blood is rotating here, there is a chance of clotting. So we have to give heparin. How much heparin we are going to give? If the patient is at risk of bleeding, we might not give heparin. There we have to do heparin-free dialysis. If patient is at risk, probably minimal risk, a low heparin dose have to be given. If it is high, for example, the thrombus risk is high, a normal heparin have to be given. The units, the dialysis technologists might be aware, 5,000 international unit to start with, and subsequently probably 1,000 unit per hour might be required. How much heparin to give, you have to be aware which anticoagulant to give. Most of the dialysis unit use heparin only. Whether to use some other anticoagulant, that and all specific prescription, at least for heparin, make sure you are giving the order for how much heparin to use. And apart from this, two other subtle parameters: how much sodium you want in the dialysate. How much sodium, this side, how much sodium you want. For example, a patient sodium is 130, probably you need a sodium similar approximately. Suppose sodium is set at extremely high level, let us take 158. There is a gross difference, patient might develop symptoms. A person who is seeing the video till now might be having doubts, or 158, how come it will be set in the machine? It can be set. Why this can occur? Because a dialysis technologist for the previous patient might have set that parameter and he might have forgot, or the reset button, or by error. Any reason might be there. Why pretending to this video? To say sodium have to be adjusted, and on average it might be 139 in the machine. Some machine it is 135. It is the software or the person while initial orientation of the machine, they will set it. So accordingly the sodium have to be checked. Suppose if it is set at similar level similar to the patient, well and good. Subtle changes is required in CKD maintenance hemodialysis patient. And the last one, potassium level. If the patient potassium is low, you have to set the potassium at higher side in the dialysate. If potassium is already high, we can use a 2 milliequivalent potassium. Potassium also have to be instructed. These are the major dialysis prescription you have to give. So overall 6, don't forget, always give this instruction to the dialysis technologist. Adding to this video, only these are there, or any other parameters are there? Apart from this, temperature, the dialyzer membrane, whether to reuse it or not, erythropoietin and levocarnitin if required, any antibiotic to be given after dialysis. These are the extra information if required you can add. Calcium, glucose in the dialysate can also be adjusted. These are in-depth adjustment which a nephrology resident might be requiring. The general physician who is handling dialysis might not require. But overall, the initial 6 prescription parameters I have told, those are required. With respect to individual prescription, for example heparin and all, there are already videos in the same channel. You can go through it individually. We have discussed regarding all this. Bye bye.